Welcome, everyone. Thank you for attending our IIH Practitioner Series. Today, we are hosting Dr. Andrew Kim and Dr. John Tesouris. Today's topic will be on non-invasive findings in IIH. Dr. Kim is an assistant professor of clinical radiology at Cornell Medicine. Oh. I think we have someone not on mute. Thank you. He is a neuroradiologist, and to moderate this 1-hour lecture, we have Dr. John Tesouris. He is also a neuroradiologist and associate professor of clinical radiology at New-York-Presbyterian and Weill Cornell Medicine. So thank you both for joining us. We're very excited to hear about some non-invasive findings with IIH, because as we know, a lot of it is symptomatic and idiopathic. So we'd love to see what an MRI and other imaging tools.
Another word wrong.
So we'll see if we can mute some people and let you get started.
Sounds good. All right, thanks so much, Edith. Thank you all for joining in on this talk. Thank you, IIH Hub, for inviting me to speak on the topic. And thank you, Dr. Tesouris, for moderating. I will, at this time, share my screen. Hopefully everyone can see this. Okay. Can everyone see that the presentation okay?
Yes, perfect.
Perfect. Okay, great. Let's get started. Don't have any disclosures to comment. So I know that there have been a few other talks now from the perspective of ophthalmology, neurosurgery, interventional radiology. And so my talk will be on from the perspective of a diagnostic radiologist, specifically a neuroradiologist. And so this talk will be on imaging findings of idiopathic intracranial hypertension. And assuming that many of you have gone through the IIH Hub website and have possibly been in on some of the other prior talks, I'll just spend one very brief slide on just going over the basics of IIH before we move into the imaging findings. It is a clinical entity of uncertain etiology, hence the idiopathic part of the name, characterized by elevated intracranial pressures, which can be proven via lumbar puncture. And the lumbar puncture usually also confirms a otherwise normal CSF composition. And these patients very commonly present with headaches, the vast majority of them, around 90%, visual changes, which can occur in more than half of patients that you see, 60 to 70%, and pulsatile tinnitus, which can occur in up to half, maybe even slightly more than half, in 50 to 60% of patients. A lot of these patients can demonstrate papilledema on fundoscopic exam, usually done by an ophthalmologist. And IIH classically affects overweight women of reproductive age. And so in terms of imaging, the question is, why do we need it? What's its purpose in the whole diagnosis of IIH? And it's really twofold. Number one, we want to rule out secondary causes of elevated intracranial pressures. There are other things that can cause it. Elevated pressures, such as a brain tumor, venous sinus thrombosis, hydrocephalus. So it's a slew of other factors you want to rule out. Sorry, what was that? Okay. And the second reason for imaging is that there are multiple imaging findings associated with IIH that can really help suggest that diagnosis. So when it comes to imaging, there are two different studies that are probably the most complete in its evaluation when it comes to imaging. One would be getting an MRI brain for your patient. Many times, if you can get an MRI orbits, that would be even better. In a lot of imaging centers, an MRI orbits usually contains some sequences of the whole brain as well. And this can be done as with and without IV contrast.
شوف يعني إن شاء ما صاب كلمك إن شاء الله الله يرضى عليك.
Sorry, I think you need to be muted. But with and without IV contrast, Most findings can be seen without a contrast study, but there are few, namely there will be one that we'll be talking about that you can see with contrast. And the second type of study you want to get is an MR venography of the head, and this can be with or without IV contrast. And just to clarify for any of the physicians that are not as familiar with MR venograms, you can assess the major dural venous sinuses without IV contrast. We have certain techniques, time of flight technique, phase contrast technique, where you can create contrast between flowing blood and stationary tissues, taking advantage of differences in the magnitude and phase of magnetization. I won't go into too much detail on how the techniques are actually done or the physics of it, but just know that there are techniques we can do with MRI where you can assess the major dural venous sinuses without IV contrast, as opposed to CT venograms where you would always require some sort of iodinated contrast. So just keep that in mind. But you can certainly get an MR venogram with contrast as well. There have been other, there are physicians that will sometimes order CT studies, and that's completely fine too. Just keep in mind some of the findings that you can see in IIH may be missed on CT, as well as CT also being with ionizing radiation. And a lot of the patient population in IIH are of reproductive age, right? So they're a little younger, so you probably want to be careful about giving them ionizing radiation. So just keep that in mind. So here's a list of the imaging findings that we'll be going through. We have a list here. Some of them are highlighted in orange. Those will be the more common findings that you'll see and that you'll look for in IIH imaging. So just keep that in mind. The third one here, the transverse sigmoid sinus junction stenosis, has been found to be the most sensitive and specific for IIH. A close second will end up being the empty sella, which studies have shown to be in up to 80% of patients, 70 to 80% of patients. And as well as orbital findings that we'll go through. We have the flattening of the posterior globes that we'll see, intraocular protrusion of the optic nerve heads, optic nerve head enhancement, which can also come with some diffusion restriction, and optic nerve sheath dilatation, which can also be very tortuous. So those have varying degrees of frequency that you can see on imaging in patients with IIH, upwards of up to about 50%, some of them a little bit lower. And finally, we have these white colored findings that will also go through some of them, but those are less common. They can definitely be seen. So things that you want to keep in mind when you're looking at imaging. Those are prominent skull-based arachnoid granulations, and they have certain related complications that we'll go through. Cerebellar tonsillar herniation, as well as slit-like ventricles, which are a somewhat less reliable sign of IIH, but something you can sometimes see, specifically slit-like lateral ventricles. So at this time, we'll walk through 4 different patient cases that will show a different combination of these findings. So let's do that now. We have our first patient here, who is a 28-year-old woman who comes in with blurry vision and headache, as well as bilateral papilledema, demonstrated on fundoscopic exam. So the imaging this patient ended up getting was an MRI orbit with and without IV contrast, and MR venography of the head with and without IV contrast. But those are the two. So on the left is our patient. On the right is just a normal patient as a normal reference. And I want to first bring your attention to the right-sided image with an arrow pointing to a normal patient's sella turcica that contains a normal appearing pituitary gland. You can see the anterior pituitary gland, and right behind that is a slightly hyperintense bright T1 signal demonstrating the posterior pituitary gland, as well as the pituitary stalk. So those of you that are not as familiar, the front of the head is on the left, as you can see sort of from the shape of the outline of the head, and the posterior aspect of the head is to the right. And these are sagittal T1 sequences. So our patient on the left, you can see that the sella turcica looks pretty empty relative to the right. So you can see that most of this is dark in appearance, matching the signal intensity of CSF. And that makes a lot of sense if you really think about it. You know, in a patient with elevated intracranial pressures, you can imagine that the CSF space is really just trying to push out and push into any direction it can. One of those spaces being the sella turcica, which results in a flattening of the pituitary gland that is essentially pancaked along the inferior aspect of the sella turcica. Just an interesting note, up until recently, it's been widely thought that one requirement is a dehiscent diaphragma sella along the top of the sella turcica for the CSF to really push through and flatten and remodel the sella turcica, which can become very expanded in appearance as well, as we'll see in some other future examples. But there is a growing body of new data and evidence that even in the setting of an intact diaphragma sella, you can get remodeling of the sella turcica. So just an interesting tidbit. So this patient also, as part of the orbits MR imaging, got an axial T2 sequence of the orbits. And you can appreciate here that there is some flattening of the bilateral globes. You can see that instead of being the perfectly round shape of the globe, you can see where the optic nerve heads sort of insert. You can see that it's flattened. Here's another view of the same patient, just one slice off. You can see that there's some flattening right there, as well as the optic nerve sheaths, which look like they are probably a little dilated distally as well. You can see that there's the optic nerve, which is a little darker in signal, and you can see that there's brighter T2 signal surrounding that optic nerve, representing the CSF. So the CSF space is sort of distended distally there. And here's just other imaging examples of optic nerve sheath dilatations in other patients with proven IIH. You can see that there are varying looks to it. And just a quick note on optic nerve sheath dilatation. There's a lot of literature out there that goes through certain measurement thresholds for what would be considered dilatation or not. There's some variation to it. So in the end of the day, practically speaking, a lot of times we'll call this qualitatively. But just to give you an idea, a lot of the papers out there sort of mark 5 to 6 millimeters in diameter as sort of the upper limits of normal threshold for optic nerve sheaths. So just to keep that in mind. And so our patient also got MR venography imaging. So this is what I was referring to with the left image actually being produced via time-of-flight technique, and the right image here being produced via phase contrast technique. And we can see that, just to orient you guys actually, the top is the front of the head, the bottom of the image is the back of the head, and the left side of the image is actually the right side of the patient. So that's typically how we have it. You can see that there's a superior sagittal sinus, a dominant right transverse and sigmoid venous sinus with a more hypoplastic left-sided sinus. But along the dominant right distal transverse sinus, you can see that there's this focal severe stenosis. You can appreciate that on both techniques used for this MR venography. So given those constellation of findings, there was definitely a suspicion for IIH. And part of the workup is to do a lumbar puncture, which can prove that there are definitely elevated internal pressures. So this was actually a patient where I did the CT lumbar puncture for the patient. And I found that there was a very elevated opening CSF pressure in the 40s. And just as reference, the normal range typically is between 8 to 20. So in this case, with the confirmation of the elevated intracranial pressure, the patient was started on acetazolamide, carbonic anhydrase inhibitor, and the patient's headaches and visual changes all resolved. So this is one nice case where there was accurate diagnosis and treatment, and luckily in this patient's case, acetazolamide was all that was needed to really fully resolve all the patient's symptoms. So just in summary, for this patient, we saw an empty sella, flattening of the posterior globes, optic nerve sheath dilatation distally, as well as the transverse sigmoid sinus junction stenosis. Right. So again, we may not see all of the possible symptoms that you can see in IH, but many times you'll see some sort of combination with, again, just to reiterate, the ones in orange, the ones that you're specifically looking for, as those will be the ones that would be most frequently seen. So, all right, let's walk to our second case. Here we have a 36-year-old woman with blurry vision, headaches, tinnitus, and papilledema also found on a fundoscopic exam. So this patient also got the same set of imaging, got an MRI orbits with and without IV contrast, got an MR venography of the head with and without IV contrast. And we have the same setup here. On the left, we have our patient. On the right is just is the same normal patient as normal reference. And you can see that our patient on the left has the same empty sella. You can see that there's this really flattened pituitary gland along the inferior aspect of the sella turcica. And again, these are sagittal T1 sequences through the midbrain, the midline of the brain. So this patient, as part of the imaging, also got axial T2 sequences through the orbits. So in this case, there was no flattening of the posterior globes. There was no optic nerve sheath dilatation. So always just keep in mind that you may not see all findings again, and there may be different variations of findings that you can see in every different case. Here, as we scroll through near the skull base of the imaging, you can see it circled that the patient's bilateral mecal caves are actually quite prominent. And on the right, you can see that they're somewhat ectatic and somewhat dilated. So in addition to that, the arrows are also pointing to what are prominent arachnoid granulations along the greater sphenoid wings, the biggest one here being on the left side. So this again makes sense in line with sort of the pathophysiology that you think about with the empty sella, that the CSF space in the setting of really elevated intracranial pressures are really trying to push out and towards any direction that it can. So unsurprisingly, you can it sort of makes sense that a lot of it is pushing through some of the foramen in the skull base, namely here, the mecal caves, as well as along and through arachnoid granulations that can become really prominent, really big, and be considered arachnoid pits. So here's another example of the same patient. If you scroll even further down, where you have an example of that prominent arachnoid granulation, that arachnoid pit, kind of extending into the right petrous apex right there. So this is a patient where you have all these prominent arachnoid granulations. And within the same MRI orbits exam, we have a T2 flare sequence here showing different views. So this is the axial view, the sagittal view, and the coronal view, different plane views. And I just want to draw your attention to that largest prominent arachnoid granulation that was along the left greater sphenoid wing. And you can see, hopefully with the signal characteristics, that there looks like there's mild herniation of brain parenchyma through that arachnoid pit. So this looks like it's a developing cephalocele. And in this case, specifically a developing encephalocele, which by definition means some of the brain parenchyma is also herniating through. And it's in these kind of cases where rarely you can run into clinical scenarios where a patient with IIH can actually present with seizures. Any situation where brain is irregularly or abnormally protruding through any kind of foramina, any kind of prominent space, you can imagine that a seizure is always within the realm of possibility. It wasn't in this patient, and it's very uncommon, but it is something that you can see as a presentation in a patient with IIH. So this patient also had MRV imaging. And you can see here that in this case, the patient has a dominant left transverse and sigmoid venous sinus with more focal moderate stenosis along the distal left transverse sinus, or some people may consider this the transverse sigmoid sinus junction. And in this case, a lumbar puncture was also done and showed an elevated opening CSF pressure of 32. Like in the first case, was started on acetazolamide, which resulted in some improvement in symptoms, but it didn't resolve it completely. Given that and the tinnitus that the patient was experiencing, the patient ended up being a venous sinus stenting candidate, where the patient ended up getting a cerebral angiogram, venogram, got pressure monitoring, and ultimately got 2 overlapping stents actually placed in that region of the left transverse and sigmoid venous sinus, where the stenosis was. This is the frontal view. You may have to squint your eyes a little bit to see that stent, but you can see the correlating image here demonstrating nice, robust flow through that stent. So there's a marked improvement in that stenosis. Let me just show you a different view here. This is the lateral view. You can see a little bit better the stent that was placed in that left transverse sigmoid venous region. And you can see nice, robust flow where there used to be moderate stenosis. Now it's just nicely open. And so very nicely after the stenting, this patient actually had a complete resolution of symptoms. The headaches, the tinnitus, the visual changes, they all resolved. So this is a wonderful example of a patient that was accurately diagnosed and very nicely treated with complete resolution of symptoms. So that's really great for this patient. So in summary, this patient had an empty sella, had a transverse sigmoid sinus junction stenosis, as well as the slightly more uncommon prominent skull base arachnoid granulations. So here we move on to our third case. We have a 29-year-old woman who comes in with blurry vision, headaches. So you can already see that a lot of the symptoms tend to be very similar here, as well as right-sided pulsatile tinnitus, as well as bilateral papilledema on fundoscopy. So this patient got the same set of imaging as the first two patients. In this case, got an MRI orbits with and without IV contrast, an MR venogram of the head with and without IV contrast. And again, our patients here on the left with a normal patient as a normal reference on the right. Again, sagittal T1 sequences through the midline of the brain. And we can see that in our patient that we have an empty sella here for the same reasons, and flattening of the pituitary gland. You can see that compared to the first two cases, this one's a little bit more expanded. So you will be able to see varying degrees of expansion involving the sella turcica as it remodels. So our patient here had flattening of the posterior globes. You can see that with the where the arrows are pointing to, as well as some tortuosity of the optic nerve sheaths, as you can see here where it's circled. You can see that it's tortuous too, because even on these given slices, you can see that some portions of the optic nerves just really cut out of view. You can see here that there's like this sort of dark band looking thing here on this image, a little dark band here. That's just sort of proving that there's this tortuosity going superiorly and inferiorly and sort of out of the axial plane and cut of the image. And here's the final third image, just showing that tortuosity a little bit more on the left side. And one interesting thing that we saw on this patient that was not seen on the first two patients, we got post-contrast axial T1 imaging, as well as a post-contrast T2 flare sequence on the right here. And this is where a contrast exam can catch some subtle findings that you may not see on a non-contrast exam. And here we see some kind of fuzzy nodular enhancement along the posterior aspect of the globe, right here, where the arrows are pointing to. And you can really see it stand out on that post-contrast T2 flare sequence here. So that is an imaging evidence of intraocular protrusion of the bilateral optic nerve heads, as well as enhancement of it. So this has been sort of described in the literature. And there is one specific one I'm thinking of, Dr. Kennedy's paper in 2019 that actually finds that it's a very sensitive marker for moderate to severe papilledema. So when you see a finding like this, it's most likely that the patient has at least a moderate degree of papilledema. This patient ended up getting MRV imaging. Here's 3 different slightly views of the same MRV imaging. And you can see that the patient has a dominant right transverse and sigmoid venous sinus, and that there is this severe focal stenosis of the junction right there. So you can see this nice robust flow. And then if you look at actually the middle and the right side image, it sort of gets some of the collateral vasculature out of the way there, where you can see that it really tapers, it really narrows there. So in this case, the patient had a lot of the findings that you would commonly see in IH. And given the patient's blurry vision, the at least moderate to severe papilledema. An LP was actually decided not to be performed at this time due to near certainty of diagnosis. Most of the times you will get an LP, but I think rarely in certain situations, it could be fine to not do it. Based on this specific patient's MR findings and clinical symptoms, including months of pulsatile tinnitus, the patient was actually just started on acetazolamide, which did lead to some improvements in symptoms, but it didn't resolve it completely, and the pulsatile tinnitus itself was unchanged. So this patient also was thought of as a potentially good venous sinus stenting candidate, and got a cerebral angiogram, venogram, which you can see here, which is a nice correlate with the MRV imaging that the patient got that I showed you just earlier, where you can see that the dominant right transverse and sigmoid sinus here, you can see that really focal severe short segment stenosis. So exactly what we saw in the MRV imaging. So it's nice to see that correlate on the cerebral angiogram study that was done here. This is the frontal view, and this is the lateral view. And so actually just to quickly go back, they did a pressure monitoring there, saw that there was definitely a significant pressure gradient between the proximal between the proximal aspect and distal to the site of the stenosis. And so was an appropriate venous sinus stenting candidate. The stent was placed. You can see here a nice frontal image here, and you can see it's related nice, robust flow. You can see, judging by the diameter of the vessel there, that the stenosis is very much improved. And here's actually a nice example of MRV imaging taken pre-stent and post-stent. So the left is before stenting, and the right-sided imaging is after stenting. And this is in the coronal plane. You can see that the patient's right transverse sigmoid junction is on the left side of the image, and the arrow is pointing here towards what I want to draw your attention to, the more curvilinear appearance of that bright signal right here. That's actually the very severely stenotic right transverse sigmoid junction. And you can see that after the stent, that there is a return of a nice, robust diameter of that vessel. Just keep in mind, whenever you do MRV imaging after stents, some of the signal can be lost. So you'll notice that there is a little bit of decrease in the actual quality of the signal because of the stent itself. But it's important to just keep in mind that as long as you can see the signal, and as long as you can get a good idea of the actual diameter of the vessel, that's what's important. And you can see here that there is a nice return of its diameter to something a lot more robust compared to the hypoplastic left side. So here's this more MRV imaging of the same patient after stenting. And again, like I mentioned, you can see some signal loss related to the actual stent material, the surgical hardware. But if you squint kind of carefully, you can see at least that the actual diameter of the vessel has returned to something with vast improvement of its stenosis. So just to kind of better picture that, on the left side here is pre-stenting, and here is post-stenting. So here again on the pre-stenting, you can see that it really tapers to something very narrow. But here, even through that signal loss, if you squint a little carefully, you can see that the diameter of the actual vessel is much, much better, where the arrow is pointing to. So here, in this case, after the stenting, the patient had very nicely a complete resolution of her symptoms. The headaches, papilledema, and pulsatile tinnitus were gone. And in that setting, was gradually weaned off of the acetazolamide. So this patient, the patient checked off a lot of the findings that we can commonly see. In fact, pretty much all of them. Had an empty sella, flattening of the posterior globes. There was intraocular protrusion of those optic nerve heads. The optic nerve heads were enhancing. In this case, it wasn't diffusion restricting, but it is also another finding that you can see, which can be seen on non-contrast imaging. The patient had optic nerve sheath tortuosity and had the transverse sigmoid sinus junction stenosis. So we'll now get to our last case here, who was a 60-year-old woman with a history of Chiari-1 or Chiari malformation. It was actually exactly a Chiari 1.5 malformation, but we don't have to go into the detail, with gradually worsening headaches and bilateral tinnitus. So this patient ended up getting an MRI brain without IV contrast and MR venography of the head with and without IV contrast. So here is imaging both sides reflecting our patient actually. Again, this is a sagittal T1 sequence through the midline of the brain. And we can see here, compared to the other 3 prior cases, we can see an empty cella, but it's really remodeled here. You can really appreciate that it's really expanded and that you have a very thin pancaked pituitary gland there. On a slightly different offline midline view, you can see that there is downward herniation of the cerebral tonsils. So that's definitely something you can see in IIH, but that's also something sometimes you can see in other diagnoses. So here it's like a really good way to remind everyone that patients can come with multiple diagnoses, and in this case had a diagnosis of Chiari malformation. So just keep in mind that while you can see downward cerebral or tonsillar herniation IIH, keep in mind that there are other entities that can do the same. So in this patient, it's hard to say exactly if a lot of this, at least in this time shot of an MRI, was contributed to by IIH, or at least in part due to Chiari malformation. So just always keep in mind that there can be other confounding diagnoses that you always sort of have to consider when you do a workup in a patient with IIH. Here are some other nice examples of that cerebral tonsillar herniation that you can see in other different patients with proven IIH, where you can really nicely appreciate the downward cerebral tonsillar herniation, which again makes sense. Similarly to the empty cella, similarly to the prominent arachnoid granulations that can occur when you have that elevated intracranial pressures, structures can really try to push outwards in any direction that they really try to, in which they can, including through the foramen magnum, where you can get downward cerebral tonsillar herniation. So in this case, the T2 sequence to the orbits actually did not demonstrate posterior flattening of the globes or any kind of significant optic nerve sheath dilatation. Again, you don't always have to see every single finding. You might see a different constellation of findings. And as we go down on the T2 sequence to close to the skull base, here, like one of our other patients, you can see what looks like very prominent dilated bilevel metal caves, probably more prominent than the other case that we saw. These are just other views where as we go down more inferiorly, you can see that there is a contiguous arachnoid pit that's really extending into the right petrous apex, a little bit to the left petrous apex, but even more so on the right there. So you can really appreciate that abnormal finding that you normally wouldn't see in a normal patient. Here are coronal views of the same thing. And you can appreciate in the coronal view, the bilevel metal caves that dilated and ectatic, as well as that really, that contiguous arachnoid pit extending inferiorly into that skull base, where you can, and into the petrous apex, where you can see that this really abnormal finding. And in this particular patient, near the left inferior anterior frontal convexity, we can even see a cephalocele here. So you can see this is the coronal view of a T2 sequence, axial view, and you can see here in the circle that there is a protrusion of the meninges through the left fovea ethmoidalis. So it's protruding through it. We have a cephalocele here. We can see the nice T2 bright signal, which demonstrates CSF. One can question that maybe even a little bit more darker signal intensity matching brain parenchyma could be a tiny bit herniating through. At the very least, we have what looks like a meningocele. So in these kind of settings, another presentation that you can more uncommonly see in IIH patients are CSF leaks. So patients could present, for example, if they had imaging like this, it's possible the patient could have presented with clear CSF rhinorrhea. In this case, the patient didn't present with that, but that is another uncommon presentation for an IIH patient, that they can present with CSF leaks because of all of these prominent arachnoid granulations, cephaloceles that can form that really just protrude out and eventually leak CSF. So that's just something important to keep in mind. This patient had MRV imaging and has a dominant right transverse sigmoid venous sinus with a focal moderate to severe stenosis here. Two slightly different views of the same thing. We can see that really tapers and gets very stenotic there. And so this patient ended up getting a lumbar puncture, demonstrating also an elevated opening CSF pressure, and didn't yet, but is currently planned for a future cerebral venogram, where we'll do venous pressure monitoring and hopefully be an appropriate candidate for venous sinus stenting, which will hopefully help with this patient's symptoms. So in this case, we had an empty sella. We had a transverse sigmoid sinus junction stenosis, as well as some of the more uncommon findings that you can see in IIH, the prominent skull-based arachnoid granulations, and we'll leave that check mark for the cerebral tonsil herniation, but again, always to keep in mind that there are other entities that can lead to cerebral tonsil ectopia. So just make sure you don't have those confounding factors. So this is just a nice take-home slide. If there's one slide you're going to take away or save from this talk, this is probably it. These are a list of pretty much all the findings you can see in IIH. And again, the ones in orange are the more common ones that you can see on hopefully MR imaging that you're getting for the patient. And even among all these, again, the transverse sigmoid sinus junction stenosis being the most sensitive and specific for IIH. So these are some of my references, and thank you so much for tuning into this talk. And at this time, I'm done with my talk, but happy to open it up to any kind of Q&A, any kind of questions that anyone might have. So I'll stop sharing at this time. Can also
Dr. Kim, thank you so much for that presentation. It was great. A couple of questions. The first one pertaining to the maybe encephalocele, meningocele, and the dilated Meckel's cave. What do you think the etiology of that is? Is that just skull-based remodeling in the setting of intracranial hypertension that's been chronic and pretty severe for a long time? And then the second one, you pointed out radiographic evidence of papilledema. I've come across some literature about measurements of the optic nerve sheath head 3 millimeters behind the posterior wall of the orbit as surrogate for ICP elevation. I was wondering if you could speak to that, please.
Yeah, so it was actually, I showed it in one of the slides, some examples of the optic nerve sheath dilatation. Just to answer your second question first, I think you're talking about two slightly different things. The most sensitive imaging marker for papilledema would probably be the intraocular protrusion of the optic nerve heads and its possible related enhancement and even diffusion restriction. The other thing you're talking about is some papers describing measurements of the optic nerve sheath itself. Some papers describe, trying to measure it a certain distance behind the globe, like you were just saying. There are, like I sort of mentioned before, papers with varying measurements. Some of them offering a measurement of about 5, some of them 6 millimeters in diameter, measured a certain distance behind the globe that can clue you in as to the upper limits of normal. So anything over that could potentially be considered optic nerve sheath dilatation. Again, there are varying numbers, which is why it's hard to sort of settle on just one holy grail number, I would say. But it's something that you can definitely take into account, definitely do a measurement on your own to just get an idea to sort of qualitatively decide whether you think it's dilated or not.
Yeah, let me add something to there, Andrew, let me add something here, sure, yeah. Dr. Nevis. I've actually reviewed a few of those papers where they measure the optic sheath diameter and they try to correlate it with ICP. The measurements tend to not be accurate. And there's a huge quantitative spread as to what different papers show. It's not easy to get the high resolution imaging that you need to get consistent measurements, depending on the tortuosity, depending on the plane that you're imaging in. So there really isn't great data as to that being helpful, like quantitative measurements. But as Dr. Kim said, we can see severe papilledema on MR these days. We didn't used to be able to see that, but we can actually see the papilledema. But the gold standard is still going to be the ophthalmologist endoscopic exam. So I'm going to defer to the ophthalmologist when it comes to how severe the papilledema is. But when we see it, that helps us with the diagnosis. And I'll let you take the other question, Andrew.
Yeah, the other one, I agree actually with what you were saying. I do believe that it's through the chronic setting of elevated intracranial pressures that you're getting this skull-based remodeling. Again, any CSF space and structure really trying to push out in the setting of an elevated intracranial pressure, and therefore remodeling osseous structures. And any kind of protrusion that sort of existed through osseous structures just getting bigger, including the Meckel cave, any foramina in the skull base, really, as well as arachnoid granulations. So
yeah,
so
I agree with
it's
the weakest. Yeah, it's the weakest point in the skull. So these arachnoid granulations, Meckel's caves, the cribiform plate, where the bone is the thinnest normally, is where you're going to get these chronic pressure erosions, and that's where we, as neuroradiologists, we're actually trained to look at those areas specifically to look for these cephalocele dehiscence, CSF leaks, because we know they do occur in chronic IIH patients.
Awesome, thank you.
Mm-hmm. Certainly.
If there are no more questions left for Dr. Kim or Dr. Tesouris, then we'll go ahead and end our lecture for today. Thank you guys so much. I'm myself a physician assistant, and I don't look at MRIs very often, but I have to say, Dr. Kim, you did an excellent job. Even for my eyes, I didn't need to squint. I was able to see all of your findings. So I really do appreciate it. I learned a lot today. I'm not so afraid to look at MRIs of the brain, but and thank you so much, Dr. Tesouris, for adding some additional points on the chat. I think it's going to be very helpful. If anyone has any questions that we may have missed, we'll just forward them to Dr. Kim and Dr. Tesouris and connect anyone if possible, if they need it. Thank you so much for your time. And we are going to end the lecture with following on our next lecture on April 13th at 6 p.m. Eastern Time. It will be Dr. Stephanie Chen. She is a neurosurgeon at the University of Washington. She will be speaking on venous manometry, and the moderator will be Dr. Vashish Srinivasan. He is a neurosurgeon and an assistant professor of neurosurgery at UPenn. He actually spoke for us at the end of February on venous sinus stenosis. So thank you for those great case presentations, because I think it all ties in together with venous sinus stenosis, IIH, possibly and hopefully ultimately treating these patients that have stenosis with stenting. So we'll see what we can learn on April 13th, and that'll end our lecture for today. Thank you so much.
All right. Thank you all. Thank you again, Dr. Tesouris.
Thanks everyone for joining. And thank you, Dr. Kim. That was a very, very good presentation. Excellent.
Thank you. And I put in my email address as well in the chat in case anyone ever has any questions. Feel free to email me. Always happy to connect and answer any questions.
Thank you. We won't inundate you with too many emails.
Yeah, no worries. Yeah, always happy to answer any questions.
Thank you.